Hello, everyone. Welcome and thank you for joining the first webinar in our Health Policy in 2025 webinar series for the Center for Advancing Health Policy Through Research. Today's webinar topic will be Understanding Site-Neutral Payment Policies, a Potential Path to Reduce Healthcare Costs. So today we'll be discussing site of care payment differentials and their impact, the potential for site-neutral payment policies as a strategy to address these payment disparities, the potential impact they might have to reduce healthcare spending and limit provider consolidation. I'll now pass it to our moderator, Andy Ryan, Director of the Center for Advancing Health Policy Through Research and Professor of Health Services Policy and Practice.
Welcome, everyone. So glad that you're joining us today. I will be moderating today's discussion. So Congress is in the midst of its budget reconciliation process where they're looking to shave spending from the federal government. One strategy that Congress is considering is site-neutral payment reform. So under current rules for Medicare and many other payers, reimbursement for the same service varies across settings. For instance, for the same colonoscopy or knee arthroscopy, Medicare will pay about twice for a procedure performed in a hospital outpatient department compared to an ambulatory surgical center. Site-neutral payment reforms aim to standardize Medicare payment rates across the same medical services, regardless of the setting in which they're provided. This has been a high-profile issue in health policy with ongoing legislative and regulatory discussions about how to balance cost savings to payers from site neutrality with broader implications to care delivery from reimbursement cuts to facilities and providers. Today, we'll hear from 4 experts who will provide insights into the latest policy developments, stakeholder perspectives, and the potential future of site-neutral payment reform. First is Christopher Whaley, an associate professor at the Brown University School of Public Health and Center for Advancing Health Policy Through Research. Chris is a health economist and expert on healthcare markets. We also have Aaron Fusse-Brown, a professor at the Brown University School of Public Health and Center for Advancing Health Policy Through Research. Aaron is a former law professor and current professor of public health and expert on administrative and health law. Next, we have Matt Gallivan, a principal at Levitt Partners. Matt previously served as staff members on Ways and Means and Senate Finance committees. And then finally, Daria Pellick, a principal analyst at the Congressional Budget Office and health economist. So I will start with some questions for the panelists, but we would like viewers to feel free to use the Q&A function and integrate your perspective into this discussion. So the first question is for Chris. So Chris, could you please give us a sense of how payment differentials across care settings have impacted spending for Medicare, other payers, and the potential broader implications that these differentials have for our payments or our healthcare system?
Yeah, so just to expand on what you touched on earlier, if you're a Medicare enrollee and you get, say, a standard colonoscopy at a hospital outpatient department, Medicare will pay about $1,100 or $1,200. But if you were to get the same colonoscopy at a freestanding ambulatory surgical center, Medicare would pay about $600. And so that, roughly 2x price, or roughly a $600 difference, is actually even slightly larger among commercial payers, where the price difference is about 2x, it's about 2.5 to 3x. And if we look at a host of studies, quality is actually, in many cases, better at non-hospital facilities. And so there's also lots of additional costs in terms of patient safety and care, as well as increased travel to facilities and increased convenience of non-hospital settings. And these all have, I think, really important budgetary and healthcare spending impacts. And so if we, I'll let Daria comment on this a little bit later, but MedPet or CBO estimates that if we were just to have kind of, pretty aggressive site-neutral payment policies, then that would save the Medicare system about $150 billion over 10 years. But I think the other underappreciated aspect of site of care payment differentials is how they're really both a cause and a consequence of provider consolidation. And so that same $600 payment differential for your colonoscopy is both a pretty strong driver of increased spending, but it also creates an arbitrage opportunity, if you will, to, if you're a healthcare system, to go out and acquire physician practices and say to the physician, don't send your patients for their colonoscopies or imaging tests or what have you to the local providers that may be the best match for the patient. Send them back to us as a mothership where we're going to get paid $600 more. And I think we haven't fully understood how these payment differentials have really contributed and really been a strong driver of consolidation. And I think that's an area where there's lots to be done.
Thank you so much, Chris. Next, I'm going to turn to Daria. And Daria, could you please describe some of the different site differential proposals that have been scored by CBO? And I'm particularly interested in some of the dimensions over which these proposals vary and how those are affecting kind of their budgetary impact.
Yeah, thanks for that question, Andy. So CBO has scored a range of policies that I would put kind of in the bucket of site neutral payment policy legislation. The range on these scores is very large. They go from only 150 million over the course of the 10-year budget window to up to 157 billion over the course of the 10-year budget window. And as you're asking, the reason for this large range of scores is that there's a lot of dimensions on which site neutrality can vary. So we've seen policies that affect Medicare, where Congress can directly legislate to lower payments. And we've also seen policies that affect commercial insurers, where either we've seen direct legislation prohibiting providers from charging higher patients or prohibiting insurers from paying those larger payments, or policies that try to give insurers greater transparency into what they're paying for by, for instance, requiring that off-campus hospital outpatient departments bill under a separate NPI that is unique from their parent hospital. There's also a range of services that these can apply to, so they can apply very narrowly to something like drug administration or just imaging, just mental health visits, or they can apply broadly to any service that can be provided safely in either a hospital outpatient department or a physician's office. So for instance, MedPAC had a list of about a third of the ambulatory payment classifications that they thought could be reasonably provided in either setting. And then finally, these policies can vary across which types of providers they apply to. So there can be narrow policies that are only going to apply to off-campus hospital outpatient departments, which are those located near but off of the main hospital campus, or broader policies that include any hospital outpatient department. And we've seen carve-outs for rural providers, critical access hospitals, cancer hospitals, any other provider that's a policy priority. So the diversity in these policies leads to a wide range of budgetary effects. Most recently, CBO scored a set of policies that were just in Medicare in our biannual Options to Reduce the Deficit publication. And the size of those scores ranged from 5.6 billion over the 10-year budget window to about 157 billion, where 5.6 is what you get from only limiting the drug administration in off-campus hospital outpatient departments, paying those providers only what they would be paid in a physician's office, to the 157 billion was for implementing that policy that MedPAC has discussed, which is equalizing payments for a third of all ambulatory payment classifications.
Thank you, Daria. So I want to try to get the other side of the coin here and to say we've been talking about savings and the kind of upside of these kind of reducing these site differentials, but hospitals in particular, justify them on various grounds. And I'm thinking, Matt, if you could reflect on this question a little bit, what are some of the downsides of these types of reforms to health systems, and what would the opponents of such reforms say?
Yeah, it's been a hot button topic with very strong opinions amongst stakeholders. And it really does depend on what type of site neutral you're also talking about. As Daria was just saying, you can get into services that can be provided potentially in both inpatient and outpatient. That's not usually what people are talking about. There's the post-acute care space as well across different types of, providers in that space. But normally what we're talking about, and the stakeholders that are most engaged around the issue of site neutral are hospitals, physicians, especially independent physicians practicing in their clinics, cancer care providers, patients, and ambulatory surgery centers, and then health plans and employers care, especially when it comes to a commercial standpoint. And usually the divide is between hospitals usually opposing site neutral payments, the physician community being divided, some being very supportive because they see that their payment is less for the same services than it is for hospitals, but there also, due to consolidation, are a number of physicians that are employed by hospitals now, so they care about it from that angle. Ambulatory surgery centers being in favor of it, health plans being in favor of it, employers being in favor of it, and usually patient groups are also in favor of it, especially as it relates to implementing it in a Medicare setting, because patient cost sharing is directly tied to the overarching reimbursement for a particular service. So if you're paying 20% of the costs, if the government is reimbursing more in certain settings than in others for the same service, your costs are going to be higher. So that's why patient groups care, because you as a patient don't know that if I go to this hospital-owned outpatient department and get a service, it might be more than what it is in the physician office. But there are real, hospitals take the perspective that we are a loss leader in providing a bunch of services that don't make us money, that don't, and that in order to provide that service, which is a community good, we have to be able to offset those losses in other areas. We run a 24-hour emergency care unit. We have a burn unit, a critical care unit. And those things are important services that you don't want to see close because you are reducing our reimbursement in another area. And I think one of the major philosophical questions when it comes to something like site neutral, especially for, rural providers that don't have the same volume of patients and can't absorb necessarily the same reduction in reimbursement for certain services, is, do we think it is important for the government or payers in general to reimburse for services in a way that cover the broader costs that a hospital is providing, and doing that indirectly across all of the services? Or should we reduce reimbursement for things that the reimbursement should be reduced for and increase it for the things it should be increased for? And so that's a philosophical conversation of, how do we approach that? What is most fiscally responsible, economically, rational, and what is the ripple effect to the bottom line of these providers that could make or break whether they stay open or not?
Right. Kind of same with you here, Matt. What's on the table right now from a policy perspective? We heard kind of Daria talk through a bunch of different flavors of reform. What do you think Congress is kind of closest to moving on, or what are kind of what you see as the most likely options in the coming years?
Yeah, so I think it's one important history point is, both President Obama and President Trump have had, offered various proposals of site neutral. So it's been a bipartisan issue. There was a bipartisan provision to implement it for hospital outpatient departments. The political blowback on that initial version of it led to a fix, that grandfathered in certain hospital outpatient departments. So it shows the political consternation that comes with such a big policy change, and that's led advocates of site neutral to pursue more targeted expansions of that approach. And so most recently, in the Lower Costs, More Transparency Act that passed the House overwhelmingly last year, it was really focused on the drug administration costs and just limited to that piece. It did have, and Daria can and speak to the number. It did have a not insignificant price, savior number associated with it. So it's not to say that it was, small potatoes. But in the grand scheme of, the discussion of site neutral, it can, be much broader than that. You have had legislation introduced to, bipartisan to apply to a broader swath of the potential playing field. Dr. Cassidy and Maggie Hassan have done a version of that, to apply it more broadly. There have been some that are cancer services specific. Jody Arrington has had one on that. Lots of think tank proposals that have been out there. And I think the difference, to get to your fundamental question of what's on the table now, certainly the Lower Cost, More Transparency Act provisions are still in conversations, including from a bipartisan standpoint. There has been some discussion in a healthcare reconciliation context of, would you consider broader site neutral as a potential pay for, to lower the cost of this overarching reconciliation package. Remains to be seen whether they would want to engage around Medicare policy as part of that. But it is, the broader policy has been considered in that context.
So thank you, Matt. So I'm going to move to Aaron now. So Aaron, what do you think are the most relevant legal or regulatory considerations that influence the potential reforms that we've been discussing to site differential payments?
Yeah, I think there's sort of like a big picture legal consideration and then a more fine bore technical legal question. The big picture one is sort of who has jurisdiction to regulate any particular segment of the market. And so Congress, as we've talked about today, has primarily focused on applying and implementing site neutral payment policy to Medicare because Congress obviously has a lot of regulatory authority over Medicare, although it's not limited to Medicare. Site neutral payment policy has also been entertained at the federal level for a broader swath of commercial payers. However, I think what's interesting is that states are also starting to get into the site neutral payment policy arena. We've seen a bill introduced in New York and recently in Indiana as well, that they're looking at ways to address some of the things that states can do, particularly over the commercial market, and extend some of the path-breaking information on, site neutral payment that MedPAC has done, figuring out which of those procedures can be safely done in either setting, but really looking at it from what market segment are you looking at as site neutral payment policy in. So I think that that's one sort of big consideration, is sort of like, where is the jurisdiction? Obviously, Congress has lots of jurisdiction over Medicare, but it also could potentially expand that further. And states are more limited. They can't regulate the Medicare program, but they can regulate sort of the billing practices of the providers in their state. So that might be a vehicle to keep an eye on in terms of commercial site neutral payment reform. The sort of smaller, more technical regulatory consideration has to do with what Daria mentioned earlier, which is the sort of unique NPI, which stands for National Provider Identifier. So right now, it's very difficult to actually tell when an off-campus, provider is being billed as sort of whether it's even off campus, I guess, frankly, because the professional, services are billed under one form, and that has its, the professional identifier there. And then the facility that's, charging for the hospital outpatient component, that site differential, might just bill it under its health system NPI or a main campus NPI. And it's very difficult to line them up and actually know whether this is a service that should be eligible for site neutral payment, were it to be, because it's off campus, that it's really just a physician's office that's been acquired by the health system, and now it's being called an outpatient department of the hospital. And so what one of the proposals that's been included both in the Lower Cost, More Transparency Act and my other proposals is to create a location-specific identifier that would be on both claim forms, the facility claim form and the professional one, in order to line that up and be able to actually identify when are the services being provided in these off-campus locations that should be eligible for site neutrality. So this is like a sort of a small, in the sense of technical data fix to a larger problem, which is that we almost can't see the extent or measure the extent of site neutral payment and how much this is happening in a site differential way, because we can't totally tell in every instance when these services are being billed in this way off campus.
Thank you, Erin. So we have an audience question that touches on maybe some of the philosophical, theoretical issues that Matt raised before, and it has to do with this notion of kind of like disproportionate harm, and to what extent are we concerned that rural hospitals, critical access hospitals, other safety net hospitals would really be harmed? Number one, like, is this a concern that we should be that this should surface in the context of site differentials, and we should perhaps give some kind of carve out there? Or do we think that this is like a related issue that that the site differential payments create distortions that should be ended, and we should otherwise address payment policy to support these particular hospital groups with a kind of more direct way? So it's a question I'd like to get Chris's perspective on this, and perhaps other panelists.
Yeah, so I think big picture, many of these questions are philosophical questions on how we should finance the delivery system and what's the most appropriate way. In general, I mean, I do think that if there is a provider that's able to do something in a service at a more efficient and higher quality way, that it makes sense for the Medicare delivery system to reimburse that provider and ask the higher cost, less efficient providers to become more efficient. But that does raise the question that Matt raised, that many of hospital systems do things that are less profitable. And so if you look at like where profit margins are made in many hospital systems, it is on outpatient care, and ED services, et cetera, are certainly less profitable, and in some cases actually money losers. But I guess that kind of does raise a broader question of, should we address and pay for, as a collective Medicare system, these services that we want to have and highly value, such as emergency services, by making patients who need their MRI or their colonoscopy pay more? Or should we equalize and make sure that we're paying for these outpatient services in an efficient manner, and potentially use some of the savings to make sure that we're adequately funding ED services and making sure that Medicare is paying its fair share for ED services? And I guess the other point I'd make too is that I think this addresses Nick's question in the chat, that many, or I think nearly all the proposals do exclude places like critical access hospitals. And I think that's also, that's both important, and it's also just from a like technical standpoint, they're just paid in ways that actually don't have lots of site of care payment differentials. And so from a like billing perspective and Medicare financing perspective, it's actually cleaner just to exempt those providers.
To add on to that, there's still the question, I think, for patient advocates when it comes to critical access hospitals. No one talks about, for the most part, in the policy proposals, about doing site neutral reimbursement to critical access hospitals, but people do sometimes talk about the impact to patients by having to pay 20% cost sharing on someone that's being reimbursed at 101% of cost. That's a lot higher for someone in that community to have to pay for cost sharing. So it doesn't always have to be, we're going to equalize the payment for the provider. It could be you also just say, but we're also not going to make the patients there pay more than they otherwise would. That has a cost associated with it, but it shows that there are dials with this, and there's a lot of important policy nuance questions when it comes to especially rural. My 2 cents is this is mostly a political debate. What is politically, allows the policy to move forward, and there are just political realities about, rural members of Congress and sort of the dynamics there, and certain safety net hospitals in urban districts that it kind of is the only way that something ever gets through is going to require trade-offs in some of those policies versus sort of the pure policy view of how to proceed.
Right. So that point, Matt, is kind of saying that for this to happen, there's going to be carve outs. It's going to be kind of how one of these thinned down versions that Daria described. And, this is kind of what's more reasonable to expect than rather than the kind of the larger estimates that are hypothetically possible that we should probably, realistically speaking, expect something lower. Another question that's related to this and the thing about like the dials of the policy here is, do we think that, well, maybe let's kind of be specific here and, if we think about an example like ASCs versus OPDs or, hospital-owned clinics versus non-hospital-owned clinics, do we think that optimal policy would have site differentials of, of zero? Like, I'm just thinking, like, what are some of the theoretical arguments here that, yeah, maybe they're too high, but maybe there's a case that they still exist at just a lower level. I'm just kind of, curious what panelists think if this is another kind of avenue for reform that's kind of like a middle path that's being considered.
So just to briefly answer that, I mean, so the argument among hospitals in many cases is, our higher, 2x higher payment rate is justified because our patients are more complex and sicker and need more care needs. And so we just need to be paid more to provide those care. And if you look at ASCs, they are all healthy patients who just need less resources. Empirically, that's not actually that true. Most patients at ASCs and HOPDs look pretty similar. There is, of course, a tail. And so maybe a kind of more level setting payment policy would say, look, for many of these services, we're going to have a standard payment rate, regardless of where the procedure is done. But if a patient is sicker or does have additional comorbidities, just as we do in the DRG system, then there's going to be an additional payment bump for those types of patients, regardless of where the care is provided. That, of course, opens up a whole new set of potential payment gaming, if you will, depending on how you view these things. But that might be one way to make payment a little bit more efficient regarding site of care.
To just briefly add on to that, I think there you can get rid of the differential and still, take various approaches. It's not sort of an either or where it's site neutral or no site neutral. I think to Chris's point, how does risk adjustment play into it? It doesn't have to be at the physician fee schedule rate. You could make a policy decision that, we're going to get rid of the differential, but we're going to raise what that base payment is going to be to something that is blended in between the two. Or as Chris mentioned, and I did a white paper that laid out some of this approach, you don't have to just, the savings can be reinvested or into other services. So if burn units, as an example, a lot of hospitals talk about that. If burn units and reimbursement is a big issue, you could consider, increasing the reimbursement for burn units, for critical care units, for ED to eliminate sort of the cross subsidization that's happening. Instead, say, we're going to reimburse higher for these services that you say, are going to go away if you don't get, greater reimbursement down here, but instead pay you the zero differential for these services over here. So there's lots of different ways in which you can massage the policy, do stabilizers that reduce the concerns around, what the impact is on providers by doing this, and changing payment rates so that it's not just purely this black and white, either you keep the current system or you do the most sort of draconian view of site neutral.
Right. So, I mean, what I'm taking away from that, Matt, is this notion that, these reforms, can reduce payment levels, but part of the problem with site differentials are these kind of broader distortions that they create in terms of how the healthcare system is organized and incentives for integration that Chris mentioned. And one version of this would be to couple site neutral reforms with as Matt said, different types of stabilizers and reinvestment in care, which would perhaps decrease some of these savings from the reforms, but in other ways perhaps kind of help shore up other less profitable aspects of care delivery, just given mispricing in DRGs or other parts of the payment system. And so we can think about these two different maybe broad benefits of reform with respect to saving money, but then also reducing some of these distortions created by site differentials. I'm just kind of like going down this line of thinking a little bit more. I'd be curious to hear a panelist's perspective on this notion that, are there unexpected yet, you think plausible, financial, operational, or other patient consequences if CMS or states were really to kind of go down this path aggressively towards kind of site neutral style reform? Should we really be on the lookout for how this could, backfire and what might we want to pay attention to in light of potential reforms that are being considered in the states and federally?
So, Andy, I would say I don't necessarily want to dive straight into the unintended or possibly unanticipated consequences of site neutrality. I'd like to take a step back and talk a little bit about what are the impacts, because I think Matt started taking us down that direction, but there are a few more to mention. So Matt started talking about the cost sharing impact on Medicare beneficiaries, because of course they face a 20% coinsurance on any service. So they're paying more to go to a hospital outpatient department than to an ASC or a physician's office. I think it's also important to remember that in the Medicare context, a beneficiary's Medicare Part B premiums are set at 25% of Medicare Part B spending. So when you have higher prices for services in the Medicare setting, it's actually flowing through to beneficiaries in the form of higher premiums. The same is true in commercial markets. So when commercial patients pay more for hospital outpatient services than they would like for an office visit, for instance, then it gets passed through to higher premiums for them. And then from the federal perspective there, those higher premiums are, if you're in ESI, they are tax excluded. So that tax exclusion results in a higher deficit than otherwise would be the case. And if they're in an individual plan or a small group plan, then maybe there's a subsidy that's coming in from the federal government, and that will be higher because of these higher prices. So before thinking about the indirect or maybe less anticipated consequences, I think it's important to talk about the direct consequences, which is higher premiums for both Medicare patients and commercial patients.
Daria.
And I guess to expand on that, I mean, so I think the political or policy question is that direct cost and consequences and increased premiums and spending validate having higher payments to delivery systems, and do we think that that money would be best used by hospitals or in the form of reduced premiums? And so that's really, I think, the trade-off that needs to be made.
I'd also add, there's a coding side to all of this that gets complicated to operationalize. You have, those that are paid under the OPPS right now. You're then talking about, the physician fee schedule. So are you just equalizing rates, or are you using a unified payment system? with unified coding. You know, so you're in some ways comparing apples and oranges, but trying to equalize the payments. So there's a whole complicated operational side of this, including to like which service lines are you doing this for? And then, you know, well, what if then something gets moved from, you know, off of the inpatient only list to now being in the outpatient side as well? And like, so this can spiral into a complicated way, you know, web to operationalize really quickly. I do want to answer, there was one question about the, you know, Medicaid and, you know, and service and types of patients. I would say that one question I have is with the movement from inpatient to outpatient, we don't, and Chris would maybe know, you know, and Aaron and Daria would maybe know better. I haven't seen a lot of good data to understand the patient case mix, the quality, what's going on in sort of the ambulatory settings in this massive movement. And so I think there are outstanding questions on what are the, you know, we hear rhetorically, we have sicker patients. We hear, you know, rhetorically, we have better quality. But, you know, I don't, you know, is there data to illustrate that? And then I would also add that we have a number of payment programs, DISH, et cetera, that are meant to support other forms of paying for having a disproportionate number of Medicaid patients being served or Medicare. You know, there are questions about whether those are appropriate, whether they are provide enough, whether you know definitionally they make sense. So you can have that conversation. I think it just leads again to the philosophical question of what is the appropriate way to, do you want to account for that? What is the appropriate way to do that? And does that include paying more across all outpatient services that a hospital is providing, regardless of whether that patient is in Medicaid or Medicare or commercial, you know, what your patient case mix is when it comes to commercial insurance, where you're still getting that differential.
So I think Matt really articulated the crux of a lot of the considerations for site neutral payments. And when we look at our data on whether or not the patients who go to non-hospital versus hospital settings are actually healthier, we don't find any evidence of that. And so they, at least from terms of what we could see, look the same as the patients who go to HOPDs or to inpatient services. And in one study where we looked at when Medicare took knee and hip replacements off the inpatient only list and looked at what happened to patients or where patients went, what we found is that among the general population, there was a pretty large shift from inpatient to outpatient services where, again, costs are about half as much and quality is actually quite a bit better. But the one group that actually stayed in the inpatient setting were patients whose orthopedic surgeon was employed by a hospital system. And so that's not a patient factor, that is a driving revenue factor and retaining money for the health system rather than maybe just doing what's best for the patient.
Thank you, Chris. I'm looking at some of the questions, and something that came up had to do with CBO estimates and the extent to which they're focused on Medicare or more broadly to commercial. And I think it kind of presumably depends on some of the proposals, but I wonder, Daria, if you could, briefly speak to that point.
Yeah, I can. And I think that there was a question, I'm only lightly monitoring the questions, but I think there was a question specifically about the budget options, and those were focused on Medicare. There was not in that modeling, we were not thinking about how there might be an effect on the commercial market. That is something that we do think about, and we're engaged in research to try to figure that out. We're also actively reading things from the research community. Thanks, Chris, for all the studies. We're trying to absorb those as we go and better understand the interaction between commercial payments and Medicare payments. There are instances in which there is kind of a spillback, for instance. We had one policy where we were looking at commercial payments and making providers bill under their own separate NPI or national provider identifier. That was directed at the commercial market, but we think it might even affect the Medicare market to a small degree. If there is a little bit of, I would say, billing noise in the Medicare market, then that additional transparency that's targeted at commercial insurers to give them more insight might even have some effects in the Medicare space as well. But in general, no, these are policies that we're thinking about in isolation, with the understanding that there could be interactions between the markets, but we don't have great evidence to show that there is in the outpatient space.
Thanks, Daria. Just thinking about the commercial reform, again, kind of like a philosophical question is, why does the government need to intervene here? And maybe here's a question for Chris and Aaron. I mean, commercial payers don't need to do site differentials. They can set their own payment rules. And so why should policy be targeting, what's happening in commercial markets?
I can go first and then I'll let Chris fill in as well. I think that there's a lot of evidence that just because the commercial market isn't bound to do site differential payment, that doesn't mean they have the bargaining power. The payers don't necessarily have the bargaining power in many markets to resist such demands by the large, health systems or provider systems in their markets. And so, I think part of it is just sort of like a market failure due to consolidation, frankly. That the bargaining differentials are so great that there's even though they don't have to take price differential payments, they sort of functionally have to because of they need to include these health systems and providers in their networks. I also think that the lack of transparency on the extent of it and the sort of lack of unique NPIs in most states don't have their own sort of unique NPI requirements either. And so if it's not required at the federal level, only a small handful of states have experimented with trying to do that to create more transparency. So without that transparency, it's kind of hard to even know how much this is happening within their commercial claims. So I think that those are the two reasons. And then there's like another further reason about like sort of why payment policy might be necessary. And that is, it's just, this is in some ways a little bit about regulating the behavior of the providers, and a lot of times, both the sort of consolidation and the incentives to bill in a certain way, and so that is, I think as we see that the market of providers has gotten so consolidated, I think that's sort of what requires sometimes regulatory intervention.
Yeah, so I think it's the same two factors. So one, Medicare is kind of the tail that wags the healthcare system. And commercial payers in many cases just follow, correctly or incorrectly, just follow what Medicare does, especially when it comes to billing. But then I think, more broadly, it's likely that these same political considerations that lead to Medicare having site of care payment differentials that are relatively large also are the same considerations that commercial insurers face when they're bargaining with hospitals, and ASCs and non-hospital facilities just have very little bargaining power. And so they generally kind of take what an insurer will give them versus large hospital systems, again, in many cases due to the consolidation issues that Aaron discussed, really have lots of clout when they're bargaining with insurers and are able to just command much higher prices. But I do think that many employers are aware, and purchasers as well are aware of these issues. And so I first got involved in site of care payment differentials through studies through the California Public Employees Retirement System, or CalPERS, which recognize these huge payment differentials and recognize that the higher prices that they were paying to hospital systems came directly out of their union member paychecks. And so what they decided to do is design a set of incentive programs to basically steer patients towards ASCs and away from hospitals. And that led to pretty substantial savings. And so there are policies that purchasers certainly can be putting in place.
I would just quickly add, there's a dynamic especially on the self-insured side, where a lot of large employers want to offer a plan that, and network that is nationwide because they've got a large number of employees nationwide. You then have to go with a large carrier that is not focused on that smaller market, and healthcare is purchased at a local level. And those are the employers with the large number of lives and the large amount of bargaining power. And so, I think that there's some dynamics there in terms of marketing power and focus on an individual market and who you can say no to. But I would use the example from my home state of Minnesota, and I want to be very clear, I'm not picking on someone in, a health system individually. But do you want to be the CEO that tells your employees in the Twin Cities, you cannot, if you have cancer care, you cannot go to a world famous hospital an hour down the road in Rochester, Minnesota, because they are not giving us a fair shake from our perspective because they have this differential in site of service payment. That's for a lot of CEOs that aren't really, they didn't sign up to be a CEO to administer a health benefit. That's where they end up coming down sort of politically on the question. A lot of these questions is, I just don't want to hear complaints from my employees. I'm not gonna be the one standing up there saying, why isn't this large health system that's, super world class and important, not giving us a better deal.
Yeah, so going beyond side of care stuff, I mean, that is a fundamental problem with employer-sponsored insurance. That if all 5 of us were buying our own insurance on the individual market, we would select a single hospital or a narrow network and make that premium versus network breadth trade-off and be targeted. But then if we work for the same employer, it turns out that all 5 of us want only one hospital, but we all want different hospitals. And if our hospital is on network, we're going to go complain to HR. And so we end up with a network that includes every hospital and pay a very high premium to do so.
So kind of what I'm hearing from both of you is that on the purchaser side, it's been maybe this alignment problem around network selection there's been, I guess we'll just say potentially powerful purchasers have not really had the incentive to make a credible threat to cut out some of these expensive hospitals or expensive, entities from their networks, or plausibly threatened around site differentials, et cetera. And so that's kind of, as Chris mentioned, maybe a broader issue that we see that has led to these kind of high prices in healthcare, is the lack of discipline that large self-funded groups have kind of had by virtue of appealing to their employees and maybe interest groups within companies. Matt, did you want to comment on that?
I think everything you said is accurate. I would just also say it's a lot easier administratively to say we're going to pay 150% of what Medicare pays. And that's just sort of the general approach we're going to take. But it goes back to if Medicare has this payment differential, then that's going to be baked in to, the plan on the commercial side.
Right. And that also speaks to this potential for spillover too. If Medicare is going to change, then, it's likely, I don't know how you've thought about this, Daria, and, your modeling, but, this is what we've seen kind of again and again, commercials is following Medicare. So some substantial reform from Medicare could, again, possibly just like spill over to commercial. You're going to say something, Chris?
Yeah, I was just say to Matt's point, the state policies that have thought about this have considered this issue, and so they peg in general payment to not the exact site of care where it happened or the Medicare payment rate, but actually the payment rate at the lowest cost setting. And so if you get a colonoscopy at a hospital, you're not pegged to Medicare's hospital payment rate, you're actually pegged to Medicare's ASC payment rate and a multiple of that.
Thanks for that. Something we have focused mostly on legislative proposals here and maybe talked a little bit less about regulatory options. And Aaron, I wanted to kind of turn back to you and get your sense of kind of like what might be possible under current authority, both federally and within states, to maybe address some of the site differential issues that we've been discussing.
Yeah, I think that, in a lot of these cases, we're looking at legislatures, whether it's Congress or state legislators to make these policy changes, because there isn't a lot of existing authority. I mean, under existing statute that they could then, play with or turn these dials that we've talked about. And so I think that's why a lot of the attention right now is still focused on statutes, because a lot of the original authority needs to be put in place in order for the regulatory authority to follow. I think the exception to that would be, of course, the Balanced Budget Act of 2015, and that was what established site neutral payment in Medicare for sort of new hospital outpatient departments that were acquired or established after that period of time. And so that we do have a limited set of locations that are subject to site neutral payment within Medicare, and so I think there could potentially be more done there in terms of just auditing and enforcing and making sure that that those payments are that being tracked, that they are being correctly billed, that there's transparency about how much the site of service differential is being flouted or continued to be used in these non-grandfathered places. So I think that there is some space there, but I think otherwise, Andy, I think that a lot of the current authorities still needs to come from legislatures in the first instance.
If I can layer onto that, so Erin's right. There was the 2015 Balanced Budget Act, and it only applied to a very small percentage of off-campus hospital outpatient departments because it was only ones that were newly built after that law was passed. So the percentage that are billing, like we can see in the data, the percentage that are billing under site neutrality is growing, but it is still very small. It's the minority of even off-campus hospital outpatient departments. There have been, so the executive branch, I think it was in 2018 maybe, tried to implement site neutrality for office visits, so clinic visits, for those same off-campus hospital outpatient departments, eliminate grandfathering for the ones that already existed. And that is current law. That is current law and current policy now, but it was subject to a series of lawsuits that I think went all the way. Erin, you can correct me. I think it went all the way to the Supreme Court, and they declined to hear it. But so that's the kind of frictions that I think exist when the executive branch tries to do something unilaterally. Is there's pushback and a lot of lawsuits and sort of court frictions is how I describe that.
One other clear statutory dynamic for an administration is budget neutrality.
Correct.
Where if you start in the fee schedule, start making changes around how you're going to reimburse certain services, those changes have to be done in a budget neutral way. And now we're dealing also with physician fee schedule versus OPPS usually in site neutral. So you can't, if you go and make changes in OPPS, you can't say, well, I'm then going to take that reduction and put it into the physician fee schedule rate and increase it. It's got to be budget neutral to OPPS so that, you're going to have to then increase reimbursement in other areas. So that's a real dynamic if you're trying to do site neutral from a regulatory standpoint.
Hmm.
And to say that more precisely, it limits the scope of savings to the federal government because you have to do it budget neutrally.
So to just kind of pick up on what point that Daria just made, I mean, Erin, how concerned are you in a big picture about legal challenges here? I mean, do you think that this is pretty, the legislature should be like pretty safe with new laws, or are you kind of concerned in that there'll be kind of this whole web of challenges that could really delay and derail these types of reforms?
I mean, I think there's always there's a difference between getting it across the legislative finish line and then getting it through implementation to actually sort of see the policy take effect. And there's a lot of opportunity there. And I think that and it's not so much that it'll just be dragged into court and say that, it's hard to tell Congress it doesn't have the authority to change the Medicare program. I mean, it created the Medicare program, so obviously it can change it. Same thing with, tell a state legislature that it can't regulate the providers that it licenses in the state. So I think that there's plenty of legislative authority there. I think the difficulty is more just the details and legislating the regulatory implementation and whether all the rules that follow from that need to fill in all of these details are sort of proper and they follow directly from the legislation, and that is the authority there. Is it arbitrary and capricious? Does it go beyond the scope? And there's a lot of opportunities to sort of delay through litigation in the way that Daria mentioned. I think that ultimately legislatures, like I said, have a lot of running room and a lot of authority. And when they are drafting these policies, to be thinking ahead to the regulatory implementation phase to give clear instructions to the executive branch to make sure that that the Congress's intent or the legislature's intent is indeed followed and not sort of thwarted through sort of the long and arduous implementation process.
Great, thank you, Erin. Let me ask one more question for the panel. Obviously, it's a complex policy environment, and many reforms have been proposed to make our healthcare system more efficient. This is one of many, and I'm curious if there's other ideas, reforms, current or those that are being considered that you think interact importantly with some of these site neutral reforms. I mean, one thing that kind of comes to mind is the 340B program, but of course there's others. So, I'm just wondering, Matt already kind of got at this with this notion of budget neutrality and how site neutral, really needs to be thought of within, current constraints of, the different payment systems within Medicare, but just wanted to give the panelists a chance to maybe surface some other policy strains that might be relevant when thinking about reforms to site payment differentials.
A quick list, and I think it can go in a lot of different ways quickly. Conversation is about the adequacy of the physician fee schedule that have come up. Certainly conversations around implementation of No Surprises Act and facility fees on the commercial market side are others. Rural reimbursement, primary care versus specialty, there's some, I think, layers of that comes into play, and then all of the other funding streams that have a kind of an offshoot of this, how we fund graduate medical education, how we do DISH, there are all these other sort of pots and pools of money that policymakers have made decisions around, like we think that this should get extra money or extra reimbursement, why this shouldn't, and I think all of this has a ripple effect on those conversations, just if you get to the highest sort of philosophical level.
I also would say that there's a lot of interaction with the current discussion about price transparency and other forms of transparency that I think are very relevant. So to think about what data are made available or transparent often is very much tied to the implementation of these policies, or at least even to make the case for knowing how much certain policies might affect budgets or affect providers' financials. So I think that to think about all of these, again, not just price transparency, but location transparency, ownership transparency, sort of the whole panoply of forms of transparency that are needed to fully understand what's going on in the market.
Excellent. Well, thank you, Erin, for that. I want to thank the panelists for this excellent discussion. I certainly learned a lot. Daria, Matt, Chris, Erin, your expertise was greatly appreciated, by me, and I'm expecting the audience as well. So thanks all for joining us today, and stay tuned for future webinars from Brown Caper and our colleagues. So with that, farewell.
Thanks, Andy.
Thank you.